Thank you everyone for logging in. I'm very grateful for this Zoom that we can connect a lot easier and be able to discuss some of these topics. So I am Dr. Siddiq. I'm a retina specialist, and I know retina is kind of a subspecialty of its own, and it feels like a black box to many of the doctors in the primary care provider field. So I thought maybe by sharing with you some of the common retina problem symptoms, it would bridge that gap and make it a little bit easier to understand some of the retina disorders. And also, we have our own vocabulary. A lot of time we send letters to the primary care and it sounds kind of hieroglyphics to you. So hopefully you'll get familiar with some of our wording and some of our description as well. And yes, please feel free to ask questions at any time. So here are my financial disclosures. None of them are relevant to this talk. And here are my credentials. So one of the most common complaints that you might hear about from your patients are flashes and floaters. And what that means, they'll be seeing kind of cobwebs or black lines into their vision. And floaters are kind of like little lightning and usually on the temporal aspect of their vision. And it could be a very benign symptom or it could mean very serious retinal disease. So I'll kind of go through some of those flashes and floaters and describe what their patients are describing to you. This way you can kind of gauge who needs to be sent and how soon it needs to be sent. So inside of our eye, which is a globe, there is a gel called the vitreous gel. And that gel in embryology actually holds the vasculature that goes between the optic nerve in the back of the eye and the lens in the front of the eye. But as we get older, those blood vessels shrink away, regress, and they disappear. And then with time, the gel itself also starts liquefying. Just like any other collagen material in our body, it kind of breaks down and it collapses and forms these little vacuoles. And as that happened, the strands of gel collapse on themselves and condense, and they form this fibrils. And a lot of us can see it, especially if we're not quite in focus. We're looking at a white wall or a blue sky, and you see this little kind of worm-like appearance moving inside the eye. Now, those are benign. They're basically just the shadow of the gel within our eye, and that just requires reassurance. And usually it's a younger age group. And it's not a very shocking experience to the patient. They just tell you, oh, when I look at a blue sky, I see them moving. Now, that's a little bit different if you have patients in their 50s, 60s, and they describe that all of a sudden they get this burst of black circle with little black wispy lines coming out of it. So what they're describing might be a posterior vitreous detachment. So that gel is tightly adherent around the disc and the anterior retina, as you can see in this image on the right globe there. And then as the gel kind of collapses, it cannot support itself, and eventually it comes off or it detaches the gel from the retina. And the point of tight adhesion around the nerve, when that detaches, it forms this little circle that we call a Weiss ring, as you can see in the picture on the left. And that's what patients a lot of time describe, kind of a black circle with little tentacles coming out of it. Now, that's also usually a benign process, but because that gel is tightly adherent to the retina during the process of the vitreous detachment, it can cause a risk of tearing the periphery of the retina and causing retinal holes or tears. So a more acute or abrupt symptoms of new onset floaters in one eye, more kind of in the black description instead of grayish, that requires a referral for a dilated eye exam and to check the periphery of the retina. And I wanted to show you how we actually look at the back of the eye, because most of you are probably familiar with something called the direct ophthalmoscope, which ironically, we never use in ophthalmoscopy. We use something called indirect ophthalmoscope, which basically a headset and a 20 diopter lens in our hand. And the reason why we do that is we also have to look at the very periphery of the retina. And as a retina specialist, we are trained to also do something called scleral depression, where we depress on the periphery of the globe and actually depress the retina and see if there are any hidden occult tears or holes opening up. And that's a very special skill. I'll show you a video of kind of what it looks like on the outside. So you can see we're holding a scleral depression. Pupils are dilated, and we're looking with the headset, and we have a 20 diopter lens in our hand. And it basically inverts the image, and we can see it through the headset. But it's a very dynamic exam. So as we're looking, we're actually depressing on the edges of the eye to indent the retina. And I'll show you what that looks on the inside. And without really doing the indentation and doing that all the way around 360 degrees, you cannot really rule out any occult tears or holes. So this is basically what we're looking for. So again, the description would be more like black shadows into their vision, more acutely, more abrupt. And then when we look inside, we're looking for any spots of blood that could identify a hole or a tear in the retina. This is an example of an operculated hole. This is an example of a tear that looks like a horseshoe tear of the retina. Here's another atrophic hole that can be found. Now, it's very important to identify those and treat them right away, because treating a retinal hole or a tear with laser in the office might save that patient's sight and might save the patient from dealing with a retinal detachment. Here are some other peripheral findings that we'll look for. This might be more technical, but I just wanted you to see some of the names that you might see in our descriptions. Tufts, basically, it's almost like you can think of a cotton ball and you're pulling on it and it has little tufts. So it's almost like there's a strong traction point or a focal traction point that's causing the retina to shred in that one area. Cystoid degeneration, it looks like bubble wrap in the periphery of the retina. White, with or without pressure, as we're pressing on the retina, sometimes we see the gel actually has very tight adhesion in different areas that turn the retina white. Cobblestone is just basically atrophic spots in the periphery of the retina. Lattice, it's a very thin retina that looks like a lattice window, and sometimes it actually has holes with it. And sometimes the whole retina is split into layers, and that's called retinoschisis. So here's a video of what it looks like as we're looking through that 20 diopter lens, and as we're indenting, that little bubble at the bottom of the screen is actually the effect of the scleral indentation from the outside. And I'll play the video and I'll let you see kind of how tears look completely flat when before the indentation, and as you indent, you can see, identify the tears a little bit more. So as you move your scleral depressor, you can see these little comma-shaped or curved areas. Those are actually areas that of horseshoe tears. And if you don't do this indentation correctly, you can miss those things. Now, what you're seeing now is actually laser burns. And trust me, our view, even doing this type of exam, is not much better than this. It's really hard to get a view into the back of the eye, let alone do procedure as you're viewing with those indirect ophthalmoscope. And I'll talk a little bit more about the laser here next. So when you have a tear like that, there's a very high risk of fluid seeping under the retinal tear and slowly detaching the retina. So once we identify a tear, we want to seal it. And the way we seal it is by using a laser light and doing something called photocoagulation. We're using the laser to coagulate the tissue. And this laser creates a burn into the retina by traveling through the lens and then interacting with the pigmented tissue of the retina. And that burn creates a seal or coagulation effect. And what we want is to create 3 concentric circles around the tear to seal it, and then monitor it closely over the following 2 or 3 weeks to make sure that the tear is not spreading through that laser barrier. Now, flashes and floaters, if the patient describes flashes and floaters, but also they start describing a shadow or a curtain-like effect blocking part of their vision, then that is a little bit more serious. That's probably referring to a retinal detachment. So again, you can see here's a tear in the retina, but it spread further where fluid actually detached the retina. And then we kind of differentiate retinal detachments into MAC on and MAC off. So macula is the center of the retina, which is the center of the vision. So if a patient has the shadow in the periphery and the center of the vision is intact, then that is a retinal emergency because we want to try to save that center of the vision. So we call those macula on retinal detachment. Whereas the retina has been detached for a while or is spread further, kind of like this picture up on top, where the fluid actually went all the way into the center of the vision. They usually have the dark curtain much further into their center of fixation, and that is a macula off retinal detachment. And unfortunately, kind of the damage has been done. So that one is not as emergency, but it's still an urgent referral to take care of these patients. Most of these need to be repaired surgically to reattach the retina at that point. So that's why we differentiate macula on and macula off retinal detachment. Now, another type of flashes that your patients might describe are related to migraine-like phenomena. So it could be a classical migraine with an aura, or what we call acephalic or ocular migraine, meaning they have the aura-like effect but without an actual headache. And it could be happening in the occipital cortex, or it could be even happening in the retina. So we call it a retina migraine. And migraines are not fully understood, but it is a type of serotonin vasospasm to the blood vessel feeding these neurosensory centers. And they describe it usually colorful, zigzag-like line. It can start in one aspect of their visual field and spread. Sometimes they describe it as a smokestack or dots moving or sparkling lights or strobe lights. A lot of time it's hard for them to tell which eye it's happening because again, if it's happening in the occipital cortex, then it's happening more in a visual field. So they close one eye, close the other eye, and they tell you it's hard, I can't tell which eye it's happening in. So those are ocular migraine, and those are benign. Oftentimes we do a visual field just to make sure that their visual cortex and all the conduction between the optic nerve all the way to the back of the brain is not being irritated by different processes. A different type of flash that patients might describe is kind of like a single sparkle of light and it goes away. And those are actually related to apoptosis of photoreceptors, and it's usually associated with much severe retinal disease. So a lot of these patients have things like retinitis pigmentosa or other genetic inherited retinal disease or some form of degenerative retinal disease or toxicity. And it's literally cells that are just popping open, which are the RPE or the photoreceptor cells, and releasing the neurostimulatory chemicals that stimulate the rest of the conduction signal and cause the patient to see this quick flash of light. And we call those photopsia, which is a little different than this. This photopsia are actually artificial kind of flashes, and they usually have to do with artifact-like effect from the lens implant. Patients who had cataract surgery, they get a lens implanted into their eye, and the newer premium lenses are a little bit more fancy and sophisticated. They're called multifocal lenses, so they might have multiple rings in them at different focus. And as the light travels through the edge of those lenses, it can split the beam and cause either stealing of light or cause additional light to be registered by the retina. So they can have positive or negative dysphotopsia, where they see things that are not there because of the lens artifact. One of the serious floater that patients might describe is actually them seeing blood into their eye, and that requires an emergent referral to a retina specialist. Bleeding inside the eye is never a good sign. It could be from a tear, could be from a detachment, could be from other vascular retinal diseases like vein occlusion, artery occlusion, or diabetic retinopathy. And usually it's much darker, larger floater, worse sometime in the morning because they've been laying supine all night and the blood settled basically on top of their macula. And sometimes if the blood is mobile enough, it might settle with gravity inferiorly into the retina, which means superior in their visual field. So as you see this picture here, there's a black shadow up on top, which actually refers to the blood down the bottom. And those, there's many reasons why there'll be bleeding in the eye, but none of them are good. So those require emergency referral. Another reason why patients might see some peripheral flashes of light or photopsia is things that are actually stimulating the RPE or the photoreceptors in a improper way. So any type of mass or tumors or metastasis or melanoma that basically irritating the photoreceptors can cause this photopsias to happen. So this is actually a patient with a melanoma that needed radiation. Now, another common complaint I would imagine patients would talk to you about is their vision is blurred. And I just kind of wanted you to help understand this blurred vision in kind of 4 different categories. One is refraction, which, as retina surgeons, we have to remember that the image has to be focused on the retina for a patient to see. So it could be just their vision is blurred because the image is out of focus, meaning they're nearsighted, they have astigmatism, they're farsighted, and they just haven't been checked for glasses. An easy way to get rid of all the aberration in their lens or in their cornea is to actually take a white paper and make a small hole in it and have them look through the hole. We call that pinhole effect. And all what that does is just allows one single ray of light to focus directly through the center of the cornea, through the center of the lens, onto the center of the retina or the fovea, and you eliminate any of the spherical aberration. So if the patient can not see the visual acuity chart, the Snellen chart, and you put a hole in front of their eye and all of a sudden now they can see, okay, you pretty much fixed their problem. You can just send them to optometry for refraction. Now, if there's more to it, so there are kind of 3 categories that you have to think of when they say, okay, my vision is not good. If it's not refraction, we ruled out refraction. So you want to kind of ask about, is it central? Is it peripheral? Is it color vision? Is it night vision? So this is kind of how you can characterize their visual problem. Anything that has to do with color vision, meaning they cannot differentiate their color very well, then you have to start thinking about optic nerve disease. Because the cones in our retina are spread throughout. It's really hard to damage all the cones in the retina to give you such a color vision deficit wherever. But those cones are all traveling through 1.5 millimeter optic nerve going to the back of the brain. So if you have a disease of the optic nerve, it will give you a color vision deficit. The other category is night vision. So a lot of the inherited retinal diseases, because they affect the rods more than the cones, patients would describe their night vision to be affected so much more than their day vision. So they say, I'm okay during the day, but at night, my friends can function. Usually they're a younger age group that start discovering inherited retinal diseases or peripheral retinal disease. They say at night, my friends can see, but I can't see a thing. It's like pitch black for me. So that's a night vision problem. And the other group of vision problem would be central vision. And this actually is something called Ishihara color plates, which you can easily download on your phone or on the internet. And that would be a quick way just to check for color vision problem. And they're meant to be plates of different contrast and patients have to read them. The first one is the control, and patients with color vision, they would not be able to read these. And you have to do it one eye at a time. This is what we call an Amsler grid, which is a good way to test for macular or central vision disease. So they look at it about 12 inches away, one eye at a time with their best corrected glasses. And they're looking at the center dot and they're trying to make sure if there's any blind spot or distortions in those areas. And I'll show you what abnormal would look like. Something like that kind of a dark spot or the lines are wavy, this would be very specific for macular disease or center of the retina disease. And then we call that metamorphopsia, meaning distortion of the lines in the central vision. And there's a host of things that can cause that, but all of them need to be seen by a retina specialist. The most common one is macular degeneration, which I'll talk briefly about. So macular degeneration is a age-related disease that affects patients 55 and over. It does only affect the macula, which is the central 30 degree of the vision. And patients would start describing kind of dark spots, like missing blind spots into the central vision. And unfortunately, as the disease progresses, these dark spots can coalesce and it gives you a blind central spot. So they'll be looking at you, but your face is just completely dark. They can see all the way around you. There's two major categories of macular degeneration, what we colloquially call dry and wet, or non-exudative and exudative. And I'll cover these here briefly. So again, it's an age-related disease. It's much more common in women than men, light color irises, and that has to do with more UV light exposure through light color irises. It is a vascular disease, so patients with cardiovascular history are more prone to it. Also, fatty diet and obesity has been related to it. It is more prevalent as the population ages, so 15% of patients over 80 would have some form of macular degeneration. And if you look into the back of the eye, you see these yellow deposits that are called drusen, which are basically lipofuscin or waste material, waste metabolite of the retina that accumulate under the retina. And then they begin a process of inflammation and toxicity and thinning and degeneration of the retina to the point that you can get atrophy or complete thinning and loss of the retina. And these are blind spots in the vision. The other form, which is the wet form of macular degeneration, is the much more serious disease that requires ongoing treatment with a retina specialist. We have a special imaging tool to do a light scan of the retina. So the retina is kind of like brain parenchyma. It has 10 layers of neurosensory tissue. And using an optical coherence tomography, or OCT for short, it basically sends a laser light that gets reflected and it gets emitted and then absorbed and then reformulated in the 10-layer slices of the retina. And we use this quite frequently to evaluate if there's fluid in the retina, there's missing tissue, atrophy in the retina, what layer the fluid is in. So it's almost like a CAT scan of the eye, but without radiation, just with using the light. Here's the exudative or the wet form of macular degeneration, and sometimes they have bleeding under or in the retina. And what that means is abnormal blood vessels are creeping under the retina, lifting it up and bleeding or leaking into the retina. It's only 25% of all macular degeneration, and most of it is unilateral, meaning it affects one eye. However, there's 25% that's bilateral. We used to try to laser those in the past, but the standard of care treatment now is injections of medicine into the eye to deliver it to the retina. And those are called intravitreal injections. And I have to apologize, a lot of time we abbreviate them IV, which for you guys is intravenous. So correctly, it should be IVT, but if you see in our notes IVA, we're not putting anything intravenous, it's intravitreal. Most of the drugs that we're injecting are in this class of anti-VEGF. They're monoclonal antibody to vascular endothelial growth factor. And that's because that growth factor is the drive for the blood vessels to grow into the retina. So we're suppressing that drive by injecting antibodies to it. A lot of studies have been shown. There's a lot of different medications now that are available to be injected. As time went on, the affinity for VEGF has gotten stronger, which made it a better drug and also more longevity, so it can last in the eye longer. And they've been compared in multiple trials and pretty much all similar. Just like all other antibodies, the patients can become refractory to them. So usually you try to start with one and stay with it until it kind of fails, and then you move on to the stronger ones. Injections are actually done in the office. I'm sure a lot of your patients would mention that, they've had an eye injection, or you might have seen some bleeding onto their eye. And basically, it's the best way to deliver medicine inside the eye to be as close as possible to the retina. There's a very small part of the eye that you can go in and out with needles without damaging the lens or damaging the retina. So we call that the pars plana, and this is what it looks like from inside the eye. So this is where we put the needles in and out from. It's a semi-sterile procedure. You don't want to introduce bacteria to the inside of the eye. Patients do see floaters. They see the medicine floating into their eye. They might have some redness on the outside. They might have some irritation for a day or two. So those are all common things. But if they say, oh, I lost vision after the injection, I have pus coming out of the eye, I have big, huge shadow, and they call you, that is a serious complaint. That needs to be referred back to the retina specialist. We'll shift slightly to cover diabetic eye disease. Unfortunately, on the Central Coast, we have a large prevalence of diabetics, and I'm sure a lot of you are taking care of diabetics. So as it damaged the microvasculature in the rest of their body, it damages also the microvasculature in the retina. So diabetic retinopathy is a big category, but we have to also remember that a lot of these diabetics have much more ocular disease than just their retina. They commonly have dry eyes. They can get corneal ulcer, cataracts, glaucoma, neovascularization. So a host of things that are bad for the eye. But I'll cover primarily the retinal disease part of it. So I'm sure you all understand hyperglycemia is toxic to the basement membrane of the vasculature. It's toxic to the endothelium, and it's toxic to the pericyte, which are the supporting cells of the endothelium. That toxicity basically breaks down the basement membrane, the tight adhesions, and it breaks down what we call a blood-retina barrier, similar to your blood-brain barrier. Our blood vessels in the retina are very impermeable, so that breakdown causes these blood vessels to be more permeable, more leaky, or more bleeding into the retina. As that also progresses, then you have less delivery of oxygen to the tissue, so there is ischemia and there is necrosis, and anytime there's ischemia, there's inflammation. If you tie a rubber band around your finger turns red because it's inflamed. Then one unique thing about the retina is that it's so dependent on its oxygen supply from the blood vessels. When there is a lack of oxygen, it recruits abnormal blood vessels to grow over the retina, which are called neovascularizations, which are really bad thing for the retina because eventually they become stronger and more adherent to the retina than they should, and they pull the retina off and they cause the retina to detach, and obviously there's bleeding problems. So all these factors contribute to diabetic retinopathy. A lot of different cytokines and inflammatory mediators have been associated with the ischemic retinal disease. One of the most common problems in diabetic when they break down the blood retinal barrier is leaking. So you can see actually these yellow spots, those are fat and protein deposits into the retina. The red spots are bleeding into the retina, and also there's fluid into the retina. And retina swelling or retinal edema, especially in the center of the vision, damages the retina and also damages the vision. We describe it in so many ways. You might see diabetic macular edema, clinically significant macular edema, cystoid macular edema. For your purpose, they kind of all refer to the same thing. I'm sure you're all familiar with ICD-10 classification, but it kind of simplified it and also complicated, but it's a nice way to kind of explain what diabetic retinopathy looks like. So E10 is type 1, E11 type 2, and E13 is other diabetes. And then if you have diabetic but no diabetic retinopathy is E11-9. If they have diabetic retinopathy, then we differentiate those, whether those are proliferative or non-proliferative. And what that means is there proliferation of abnormal vessels in this eye, because if there is, that is a completely different category and different severity of the disease. That's an eye that's basically not being oxygenated, and it's recruiting new blood vessels. It's at a very high risk of severe vision loss, meaning 2200 or less. Whereas an eye that is non-proliferative, it still has disease, but that's a moderate vision loss, 2040 to 2080. That's an eye that's getting oxygen, maybe lack of oxygen, but it's not suffocating enough to recruit blood vessels. So if it is a non-proliferative, then we say mild, moderate, severe, and is there macular edema or not? If it is proliferative, then we also say, is there edema or not? If the disease is progressive and it's proliferative and they have membranes growing over the retina causing traction and pulling on the retina, then we call those diabetic, proliferative diabetic retinopathy with traction detachment. And again, we want to know if the detachment is involving the macula or not involving the macula. Here are different pictures of diabetic retinopathy with different severity. These little white spots are called cotton wool spots, and they're basically infarcts of the retina layer. And then the red spots are bleeding. You can see these blood vessels look like zigzag, and that's a poor sign of circulation and ischemia and vascular disease. We describe this as tortuosity. Sometimes we see this as telangiectasia of the vessels. Also, as the blood vessels get narrower, there is sclerosing, almost looks like a copper wire instead of being nice, healthy red. And then you see the scattered hemorrhages, dot plot hemorrhages into the retina. Picture on the left is not projecting as well, but you see these little wispy lines. When you look into the eye and you have your binocular vision, these lines are actually above the surface of the retina. They're not growing in the retina. So that's what neovascularization is. Unfortunately, they bleed, they scab, they fibrose, they pull on the retina. So this is a much more severe disease. With any vascular disease, angiography is the way to study it. So it's very common for us to do angiography in the office. We use a fluorescein dye, which luckily has no nephrotoxicity or hepatotoxicity. Its risk of allergy is less than 1 in 100,000. It's basically a fluorescent dye. So if you shine blue light on it, it reflects in green, and the camera can detect that reflected image. And I wanted to show you a quick video of how we do a fluorescein angiogram in the office. You can see there the dark areas are areas that are dead or not getting any circulation. So we call that capillary non-perfusion at the periphery. And white is the dye coming into the blood vessels. You can see these bright white areas. Those are actually areas of neovascularization or blood vessels growing over the surface of the retina. So if a patient tells you I had an angiogram with a retina specialist, you would understand what that is referring to. This is a patient with treatment. So here's a patient in January of 2019. All these white large areas, those are areas of neovascularization. They're growing at the interface of perfused and non-perfused retina. This is the black line is actually blood that is leaking or bleeding from these new vessels. And this patient had a series of treatment, including laser in the periphery, injections, and you can see the neovascularization regressing and the bleeding receding. So that is the standard of care treatment for patients. But this is something that needs to be followed up closely and then treated sequentially. There are different types of neovascularization. Again, in 3D images, these blood vessels will actually be sprouting at us or toward us. There's very severe disease where basically the area that's perfused or getting the dye is just limited to maybe 5 degrees of their central vision, but you can see the amount of dead retina all the way out in the periphery. All that black is area that's non-perfused. Again, these are the names of different injectables. A lot of them are in the anti-VEGF class. A lot of time because there's so many other gamuts of other inflammatory mediators into the eye, we use steroid or implants of steroids into the eye as well. Laser treatment is quite common. The modern day laser has a pattern-like laser, and we target the laser to the areas of non-perfusion. And by lasering, we're coagulating the bleeders and also getting rid of the dead retina in the periphery. I also wanted to show you or talk to you a little bit about our surgeries. I want to thank all of you for doing the preoperative clearance on our patients. But most of our surgeries in retina start with this word pars plana vitrectomy. And again, this is the area that we enter in and out of the eye through the pars plana. The surgeries are usually done under the microscope, and we put trocars, very small trocars, they're 25 gauge, to be able to get access inside the eye. And then we view through the microscope lens to look inside the eye. One of the trocars usually has a light pipe so we can see what we're doing. And the other trocar, we use our instruments, which can be a vitrector or scissors or pick or forceps. So yeah, retina surgery is still done manually. There's no robotic instruments to it. And they're still done under direct visualization through the patient's cornea, through the patient's lens into the retina. And I just have another video here to show you what it looks like inside the eye. And sorry, the quality might not be the best, but this is kind of taken through the operating microscope camera. So the first line that we put in is an infusion line, which is a way to keep the eye formed and inflated for us while we're working inside. And it's usually pressure controlled. And we have direct control over that. These are the other trocars that we put in. And again, we're looking through the patient's eye. There's a light pipe that goes in. There's a vitrector. Then we put a special lens over the eye so we can actually focus into the back of the eye and see our posterior aspect of the globe. The first thing that we have to remove is remove that gel within the eye. That's what the word vitrectomy is. So pars plana meaning we went through the pars plana, and vitrectomy meaning we removed that gel. If you don't remove that gel carefully, then just by going into the eye, you can actually create retinal detachments. So you have to remove that gel first. And then this particular patient had something called the macular pucker, or a membrane growing over the retina. So the next thing we will do is focus down onto the macula and use a pair of forceps to actually peel these layers of membranes over the retina. And again, you know, the view is not the best, but our view usually inside the eye is not ideal either. We're kind of doing our best through the patient's optics. So that film that we are pulling is that little shiny little membrane, and it's usually 150 to 200 microns thin. So it's a very thin layer. And right now I'm just lifting it up with a gauge, with a needle, just to grab an edge of it. And you're trying to do that without obviously ripping the retina or damaging the retina. And you can see now that the forceps grabbed it, you see a little shiny membrane coming off. And you just have to have very good stereopsis and good steady hands to be able to peel that off. And you want to peel it off in a kind of a continuous circular motion so it doesn't leave any residual traction on the retina. You can sort of see the edges coming off here in a circle. And that's what we call a macular pucker, because it actually puckers the retina. And you can see as it's coming off, you can see a bigger chunk of it. Once you get an edge and you get a plane, you just want to follow the plane all along, just like any other surgical dissection. And you get the point. Well, thank you for your attention. I think we have a little time for questions. Again, I just started my private practice here in Santa Maria. It's called Central Coast Retina. Here's my information if you guys need any referrals for retina. I do have a life outside of retina, and I like to do a lot of other activities, but I'm available for urgent and emergent retina needs. And again, thank you for your attention.